We are going to discuss gout, and it is a ureate metabolism defect. 90% of the cases are men, and it is either due to overproduction or underexcretion. Overproduction can be idiopathic or due to increased turnover of the cell, which include cancer, hemolysis, psoriasis, chemotherapy, and enzyme deficiencies, which include Leach-Nyhan syndrome, glycogen storage disease. Underexcretion includes 3 points: renal insufficiency, ketoacidosis or lactic acidosis, thiazide and aspirin intake. What are the various signs and symptoms of gout? The patient presents with sudden excruciating pain, redness and tenderness of the big toe. The attack mostly occurs at night. Fever is also common in it, and so arthrocentesis is done in order to differentiate initial gout attack from infection. The most common site is metatarsal phalangeal joint of the great toe. The other sites are ankle, feet and knees. In chronic gout, there is tophy formation. Tophy is actually the deposits of ureate crystal with foreign body reaction, and it occurs in cartilages, subcutaneous tissue, bone and kidney, and it takes years to develop. Uric acid kidney stones are also common in 5 to 10% of the patient, and there is long asymptomatic period between attacks. What are the various diagnostic tests that is done for it? Most common test is aspiration of the joint showing needle-shaped crystals. The WBC count on joint fluid is also elevated, which ranges from 2000 to 5000 per microliter with neutrophil predominance. Uric acid level is also elevated in 95% of the patient. Elevated ESR and leukocytosis is very common in acute attacks. X-ray is also done, which is normal in early stages, but later on it shows erosion of the cortical bone. Treatment, it can be studied under two subheadings: acute attacks and chronic management. In acute attacks, NSAIDs are given as an initial therapy. Corticosteroids, which include injections and tablets. Injection is given in case of single joint involvement, and oral treatment is given in multiple joint involvement. Cations of corticosteroids: when there is no response to NSAIDs and when there is contraindication to NSAIDs like renal insufficiency. Colchicine can also be given as the initial therapy. Now, chronic management. It includes diet. The patient should decrease the consumption of alcohol, particularly beer, should lose weight, decrease high purine food such as meat and seafoods. If patient is hypertensive, then stop thiazides and use losartan. Then xanthine oxidase inhibitors are used, which include allopurinol and febuxostat. Allopurinol decreases the production of uric acid, and febuxostat is used if allopurinol is contraindicated. Probenecid and sulfenpyrazone increases the excretion of uric acid in the kidney. Adverse effect of chronic treatment: hypersensitivity, which include rashes, hemolysis, allergic intestinal nephritis, and it occurs due to uricose, uric agents, and allopurinol. And toxic epidermal necrolysis or Stevens-Johnson syndrome. The various side effects of colchicine is diarrhea and bone marrow suppression.